I'm Dr. Alana Yurkiewicz, and this is Hard Medicine. All of life, in a way, is decision-making with a deadline, paired with deep uncertainty about when that deadline is. For those living with stage 4 cancer, both that deadline and its uncertainty are radically heightened. What would you choose to continue? How would you want to be treated? How much granular detail about prognosis would you want to know from your doctors? Would you view time itself differently? These are some of the questions I asked my colleague and friend, Dr. Bryant Lin, a primary care physician and clinical professor who became a lung cancer advocate after his own diagnosis of stage 4 disease. Bryant's story is interesting because Bryant is interesting. He's a self-described jolly person, and I've watched firsthand how he continues to push, to take on projects he deems important, while subtly shifting gears depending on how he feels and guesswork about his timeline. Of course, there's no right way to live with terminal illness. As an oncologist, I can tell you people with cancer have enough on their plates than managing others' expectations to react a certain way, such as performing grace under suffering. But Brian's perspective offers one honest way of living with meaning when the years, months, or even hours feel compressed. I'm grateful that he chose to spend one of those hours speaking with me and with all of you. So Dr. Bryant Lin, welcome to Hard Medicine. Thanks so much for joining me.
Great. Thanks for having me.
I'm really looking forward to talking to you today because I've known you for several years. I've known you from before you were a stage 4 cancer patient and advocate. So I want to actually start with that. Can you take us back to life before cancer? You had a thriving primary care practice. You were a clinical professor at Stanford. You've done a lot of great work. Just please take us back to the time before your cancer diagnosis.
Yeah, I've just so loved my time at Stanford. I started here 20 years ago, first as a biodesign fellow because I have an engineering background and I enjoyed business and medicine. So it was a nice way to get that intersection. And that was just serendipitous. I was able to join that program and not heard of it. But my mentor, Paul Wong, who became the chief of cardiac electrophysiology here, invited me to check it out. And I met great people like Paul Yock and did that for a year plus, and then in 2006 joined the primary care practice, first kind of as a coverage physician, then as a permanent physician. Still on the side doing several other things. That tends to be my MO, my modus operandi, to do many, many things at once.
You once described yourself to me as a project person.
I'm definitely a project person. My wife says I'm like the ultimate hobbyist. It's sort of like everything I do is sort of like a hobby, fun thing that I want to try and learn about. And over the years, the teaching roles and the standard things, seeing patients, but also starting classes. I don't think there's too many other medical schools in the country that allow medical school faculty, especially clinical medical school faculty, to start classes for the whole university. I started the consultative medicine clinic, which was a diagnostic clinic, getting a lot of challenging cases. And then, I had residents and students, and I think you went on one of these home visits with me, I believe.
I did. Mine when I was a resident.
Yes, when you're a resident. And that was really rewarding and fun. We had to stop it because of COVID, but we've had some talk about maybe restarting that. And starting companies and digital health and medical devices has been fun, and doing research. But most relevant to the lung cancer is 8 years ago, I reached out to one of our colleagues, Dr. Latha Palaniappan, and because I had this actually bad result with a patient, I gave him allopurinol, and he was a man of Chinese descent, was from Taiwan, had a severe skin reaction called DRESS. And this is known in the Asian community, in Taiwan, it's well known. If you look at the rheumatologic guidelines, they say, well, this may occur and you could consider testing, but no really hard and fast guidance. I wasn't even aware this could happen in people of Chinese descent. I've given allopurinol, for gout frequently, right? It's a common drug we give out all the time for people with recurrent gout to prevent flares. And he was very kind. He ended up in the hospital on high-dose steroids, did well. But he didn't blame me. He said, hey, I know a lot of American doctors don't know about this, even Chinese American doctors, let's spread the awareness. Let's make sure people are aware of this. And so I thought, hey, well, there's like 10 other things I can think off the top of my head that impact Asians differently than other groups in America. And so, I wasn't an expert in this. Maybe the only thing would say maybe I have some expertise in at the time was medical devices and starting companies. So I reached out to Latha Palaniappan, Dr. Latha Palaniappan, and she has a long history of doing research in this area. And we said, hey, absolutely, let's do this.
The Center for Asian American Health and Research at Stanford.
Yes, actually, Asian Health. So Center for Asian Health Research and Education at Stanford. And early on, we decided to focus on all Asians and not just Asian Americans. And then we launched about 7 years ago. And I was looking back, one of our early talks was from Professor Anne Xing, who's done lots of research in Asian health. And her talk was about screening for lung cancer in non-smoking Asians.
That was one of the focuses of the center. Lung cancer is more prevalent among Asians who do not smoke, particularly Asian women, because they tend to carry certain mutations, like actually the one you have, the EGFR mutation in their tumor cells.
Absolutely, yeah. So that's been a focus, but at the beginning we were kind of very broad, and then about 2 or 3 years ago we decided to make lung cancer our number one priority, lung cancer. Because, well, number one, it was a good area that we felt like we could move the needle. We felt like we could have impact because there were two sides. And lung cancer, as you know, is historically been underfunded. So the two sides are screening and, of course, treatment. So screening, there's more data coming out of Taiwan, which really showed that there are direct impacts and high detection rates in screening people at risk for lung cancer who haven't smoked. And so we thought, hey, we can make impact on that side. We've already been getting a lot of patients who would come in and ask us about that. And they would say, hey, in Taiwan, they do these low-dose CTs. And in the US, we don't do those for non-smokers. We only do them for smokers who've smoked, 20-pack years and quit or actively smoking within the last 15 years. So we thought we could make an impact on that, but also treatment, because there's so many new technologies out there to really drive impact. Look at breast cancer, right? Breast cancer treatment has changed drastically over the past 10, 20 years. And we hope to bring those also to lung cancer.
And I think it really speaks to being able to identify people who are at high risk for screening, because lung cancer, as you alluded to, is one of the few cancers that we do actually have USPSTF recommended guidelines for population-based screening, but they only apply to people who have smoked. And you actually have to meet a certain number of packs over a certain number of years. And so it excludes everybody else. And we are seeing these phenomenons in non-smokers, as well as just there's rising cases of cancer in young people and people under the age of 50. So you were doing all of this great work. And then I believe it was the spring of 2024 that you developed symptoms. And if I remember correctly, because I was there at the time, it was a cough that was not going away. Is that right?
Yeah, absolutely. It was kind of mid-spring. I think it was right before I was going down, because my kids had spring break and my son was a junior in high school at the time. So we were like, oh, let's go to Southern California and do some college touring. And then, I was coughing a little bit and I thought, oh, geez, it's allergies. Our colleague, Dr. Paul Ford, I think I got him to prescribe me an albuterol inhaler because I thought,
He's your primary care doctor.
He's my primary care doctor. So very convenient. I wasn't feeling too terrible. It was just annoying and maybe woke me up at night once. And I felt like maybe the albuterol was helping, but the other allergy meds, the nasal sprays and the antihistamines weren't. And then I got to the point where I could actually hear myself, not just coughing, but I could hear almost like stridor, like an upper airway wheeze. At night, especially, I could hear myself breathing, and this
has never
sound
happened to you before.
Never happened to me. And I thought, geez, my first thought was, God, maybe I have something upper airway, some sort of obstruction up high. So actually, I'm good friends with Peter Huang, Dr. Peter Huang, who's the head of rhinology. He took a look with a scope, and he's like, no, your vocal cords may be a little bit boggy, but he said, no, I don't see anything. And then, the next day I got an X-ray that was ordered by my primary care doctor, and it showed a big opacity, big white area in my right lung. So I was, of course, at that point freaked out. I thought,
at that point, did you think cancer, or did you think this is pneumonia, I need antibiotics?
So Paul had already given me antibiotics, Z-Pak, right? The classic kind of, well, your cough has been going 5, 6 weeks, treated you for allergies, let's empirically treat you for, respiratory infection, and it wasn't helping. So I thought at first thought, this is some atypical infection.
Hmm.
So I had actually had, these crazy thoughts go through your brain. I had actually had my first delayed colo, because I was 49. I should have done, but they changed the guidelines after I was 45 now.
45 now,
Now
yeah.
I know, but I think I was past 45 when they had the
Used to be 50.
guidelines.
Yeah.
Yeah, so I was kind of in that transition period. But as many doctors are poor patients as I am, I'm readily admit.
No
But
comment. Thank you.
I did get it. So 49, I'd gotten my colonoscopy, and actually part of what drove me to get it was, I had a lot of reflux stomach issue, and they took a look and just, healing esophagitis. So I had this weird thought in my mind, oh, maybe it was some weird infection from that.
Did
And
cancer enter your mind?
it did, but the hope was like, oh, I hope it's infection, 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 and
Yeah,
then cancer.
yeah,
And then I thought, oh, if it's cancer, I hope it's lymphoma, which is funny, right?
yeah.
I'm like, well, you could maybe, lymphomas in many cases, not all cases, but, it's treatable. But I was like, God, lung cancer is the worst, right? I wouldn't want to have lung
Yeah, you were
cancer.
rank ordering the
Yeah,
possibilities.
exactly. So yeah, all these weird things come through your mind. And then so I got the CT the next day. So kind of an aside for the access issues, because I've learned so much firsthand about healthcare access, which I knew, but as a patient, you really know, right, what these challenges are. I signed this waiver saying I'll pay for it if it's not approved by insurance. And then, of course, I got a bill later for like almost $10,000. Unfortunately, it was eventually resolved, but it was a very big challenge to do that. It was not non-trivial because I think the paperwork didn't go through before I got the CT.
Yeah.
So in the future, I'm never signing that paperwork again.
I mean, honestly, it's kind of a miracle that you got a next day CT.
Yeah, oh, it was a miracle I got that. It was in the morning, but I go to the front desk, so I didn't sign that, and then I go to the front desk. Oh, it's not approved yet. And of course, I'm freaking out at this point, right? So I'm like, no, I'm just going to sign whatever.
Yeah, I've signed
And,
those. I signed
and
that for an echocardiogram once, and I got a bill for $9,000.
oh, it's crazy. Yeah, you sign it. So
It go away, but it took a lot of effort and phone
oh,
calls.
crazy. And then it's funny, like if I had gone to the emergency room and done this, it would have been paid for by insurance, right?
Yep.
Which is funny, right? And it would have cost a lot more than $10,000.
So you get the CT scan.
It looks worse. It looks like there's possibility of lymph node involvement, which again still could be
Still could
infection,
be infection, still could be lymphoma.
still could be lymphoma, still could be other cancer. But I thought that would be so ironic if I developed the classic Asian lung cancer for non-smokers. I'm like, that's just too ironic for me to get that. So I got a bronchoscopy, which is like a colo, but they, put the camera in and put the needle in where they think cancer is, or the sample is in this case. I was put under general anesthesia, so kind of groggy, waking up, and talked to the pulmonologist, and he was like, "Yeah, we of course did all the million tests for infections, but he frankly told me, he's like, I really don't think it's any of those." But as the weekend went on, right, you kind of get your results slowly one by one, the infection results. So as all the infection tests came negative, I was like, okay. And then luckily, some friends who advocated for me in pathology, they said, hey, could you put this top of line? And I got the pathology by Monday, which is crazy, right? I had the procedure Friday, and then I got the results from the FNA.
How did you actually get those results? Did you see it through the patient portal yourself, or did you get a phone call?
I was simultaneously looking, which I'm not supposed to have been doing, but Paul Ford, of course, contacted me
Yeah.
right away. So it was kind of simultaneous.
All
I
at the
think,
same time, Monday.
yeah, everything sort of came back at the same time, and yeah, it showed adenocarcinoma of the lung.
And at that point, we also didn't know what stage it was.
Didn't know, yeah. So obviously, it already involved the lymph nodes because that was part of where the samples were from. So we knew it was probably a more advanced stage. And then this is the other part about access is it's very hard to get PET scans. So I think my PET scan was the test scheduled like 3 weeks later. And so I called all around, and then also had an MRI scheduled
An MRI of your
of
brain.
my brain. Yeah. So that set the staging. I
You
had 50 Mets.
you
50,
had
yeah.
50 Mets in your brain.
Yeah.
And you had some lesions on your scalp, right?
The pathologist is there, they're needling it and using ultrasound, and they're like, these are not even lymph nodes. These are like little cancer, these are little tumors. So I had one on my neck that I think you palpated. I asked you to palpate in clinic.
I didn't like
Um,
it.
yeah. And then I had a one on my scalp here, but they both turned out to be just tumors, just, pure, no other tissue, just the adenocarcinoma,
So at this
which,
point, we know it's stage 4
yeah.
adenocarcinoma. We don't know if you have one of the mutations, the driver mutations. You know, we've both diagnosed many patients with cancer. You know, you get to know patients really well. It's always this horrible, oh shit response, right? When you get a CT scan back in your inbox and that new cough or that new symptom that wasn't going away ends up being cancer, ends up being a recurrence for someone who's had cancer. Is there anything about your reaction that surprised you when you learned this was stage 4 lung cancer?
I mean, just the kind of irony of it, just that struck me first off. And then, I think because the I was involved in the diagnostic process and I'm aware and, knowledgeable, it was good because it wasn't so abrupt, right? It was kind of gradually, oh, I know I've got something in my chest. I know these are the possibilities. Oh, I know it's then okay, I know it's lung cancer. Oh, I know it's late stage. And I already knew most people with lung cancer that wasn't caught by screening, it's late stage, right? Because most people present with symptoms at, stage 3 or stage 4. I had already sent my blood off for liquid biopsy, seen my fantastic oncologist, Dr. Heather Wakely, who's the head of oncology, and she's really one of the world's leading experts in lung cancer and non-smoker Asians in particular. I met her on Thursday. Friday, I got my EGFR results back, my molecular testing back, and it was EGFR mutation, exon 19 deletion, which is 50% of Asians have an EGFR mutation. And it's
That's
good news because we have a treatment. We have a targeted treatment.
yeah.
It's so funny though. I knew, okay, I'm like an Asian. I was hoping for ALK. It's
Hoping
funny,
for a
right?
different mutation.
Yeah, I was hoping for, see, you know too much
Yeah.
because ALK survivorship is much longer than
Yeah.
EGFR.
But
So
having
I
one
was
of these
hoping for that.
targeted mutations is still, it's a good
It's
thing.
better than not having it. Yeah,
Pill, yeah,
yeah,
that can
yeah,
directly target that
yeah.
mutation. So you were started on both chemotherapy and the pill because it was aggressive.
Yeah, so I will start on that. So my first time I was in there, infusion center, and they gave me this long-acting antiemetic called Emend, and I had this reaction, and I had a big pleural effusion by that point, and I think I sat up and I coughed, maybe had some sort of reaction, and then I passed out. The nurse thought I had sort of seizures, but I think it was just tonic-clonic movements from syncope because I was only out for a few seconds, and I woke up, wasn't confused. So they brought me to the ER. And of course, later, I recently found out I got balance billed for the ambulance ride.
Oh, the ambulance, yep.
Yeah, for the ambulance ride, even though my
Oh,
insurance paid.
yeah.
And, in California, to my knowledge, balance billing for ambulance rides is now illegal in the state of California.
I want to go back to that initial conversation that you had with Dr. Wakely, your oncologist, when you know it's stage 4 cancer, you find out you do have this mutation that it's bad, it's a sea of bad news, but that's one piece of good news within bad news. Did you ask about prognosis? And how do you think an ideal conversation would have gone that first visit? I mean, how much information did you want to know? Do you feel like being a patient made you more or less information seeking than you were previously?
I think because I'm a physician, I tend to seek information on my own independently, right? So I do admit I was looking up at the survival curves, the Kaplan-Meier curves and so forth from the different studies. So we really didn't talk too much about prognosis. I think that's one I know from just experience, right? On average with populations, doesn't necessarily like you have patients who do much better and you have patients who do much worse. It's truly an average, right? So, I wasn't as worried about that. I knew the numbers, but I'm like, hey, more action oriented about what I need to do now.
Hmm.
And I was feeling fairly lousy at that point with this large pleural effusion and coughing and, up all night coughing that, I just wanted to feel better. So yeah, we didn't really talk too much about it. I think Dr. Wakely was, very good. You want to have hope. And this is something I've learned as I've gone through this process. You want to give people some reasonable hope. So, I think she may have shared stories about patients who have done very well on osimertinib and been, on that for many years. And I think that's great. You want to hear the positive stories, right? You don't want to hear the negative stories unless you know that's going to be you, right? You don't want to hear about the person who seemed to be fine, and then they passed in 3 months, because you're like, well, does that apply to me, right? It's interesting, this question, because patients ask it all the time, right? What's my prognosis? And that's the ultimate TV question. Like, you see it on TV and movies, and there's always like the movie where, oh, you're 6 months, and the person goes and does all sorts of things because they know they only have 6 months to live. But to me, in reality, I know that's so variable.
Yeah.
I mean, fast forwarding, just because it's relevant to the question, fast forwarding now, I had progression about after 15 to 16 months on treatment. And so, the average for the study, the FLORA 2 study, was I think almost 24 months, 23, 24 months.
Years.
So I actually underperformed, but my tumor burden was much higher than probably most people in the study.
And there's that famous essay by Stephen Jay Gould, "The median is not the message." I think
Yeah.
every doctor knows that, or, read that essay at some point in their medical training. And everyone has their own way of communicating prognosis, because patients do ask all the time.
Yeah.
But often they're asking and maybe they don't actually want a number. They're looking for something else. One thing I learned in my training was look for the question behind the question. What is actually driving that
Yeah.
question? And I will say, earlier in my career, I avoided giving hard numbers because I felt like it was cruel to pin somebody down to, yeah, like you said, 2 years. But now I've developed this approach that I have called radical honesty, where it is best case, worst case, most likely. And I
Right.
do include numbers because people deserve the chance to plan, knowing
Yeah.
that there's uncertainty and there's
Yeah.
this big curve involved for everybody. And you don't know if you're going to fall on one side or the other of that curve. But there's a quote from Paul Kalanithi, who was also treated by Heather Wakely at Stanford. He was a stage 4 lung cancer patient, a neurosurgeon who unfortunately passed away. And he wrote, "The truth that you live one day at a time didn't help. What was I supposed to do with that day?" And that came up when he was asking about prognosis, because his thought process was, if I have 10 years, I'm going to keep practicing neurosurgery, right? If I have 1 year, I will perhaps leave medicine and just focus on my book. And he had a daughter, you have 2 kids. So I do want to talk about decision making with
Yeah.
uncertainty. So you kind of famously started this class after you were diagnosed with cancer. It was for Stanford undergrads, I believe.
Well, anybody could take it. It was
Anybody.
open to
Okay.
anybody. So we actually had several medical students as well. We had probably almost half and half.
And you basically decided to just keep going, right? I mean, I don't want to mischaracterize your approach,
Yeah.
but as long as I've known you, like we said earlier, you were a project person. You once said to me something like, "I've designed my life to do the work that I like," or something. Like,
Yeah.
design my life to already do what I like,
Yeah.
so that having stage 4 cancer didn't really change that, because you liked what you were doing, so you
Right.
just kept going. Is that
Yeah. Yeah. No, it's totally true. I think that was a nice validation for me. I think as a physician, I kind of went through the stages of grief several times, but fortunately, I think it was only about 2 or 3 weeks where I kind of settled down. And so it's like, hey, and part of that was because I was feeling better, even despite the kind of chemo related side effects, which everyone goes through. I was feeling the cough was getting better, and then it allowed me some time to think about, well, what should I be doing? And first thought was, well, I could take medical leave, but then I was like, what do you do? You're sitting at home and by yourself, because my kids were going to go to school, and they have activities, and my wife works, so what am I going to do at home alone, right? So I love seeing patients. I don't like the other paperwork, but I love seeing patients.
Wait, you don't like phone calls with insurance companies?
Yeah, exactly. I don't like yeah, I love the
Not why
peer
you
to
went into
peer.
medicine?
Yeah, that's why, yeah. I tell patients all the time, I'm a medical doctor. I'm not an insurance doctor. So patients, a lot of times they ask questions about insurance. I'm like, I don't know. I'm not an
Yeah, I
insurance
say doctors are
doctor.
the worst people to ask insurance questions to.
Oh, yeah. So yeah, so once it settled down and my symptoms were more stable and better, it made me think about, reflect and say, what should I be doing? And, I felt, hey, this is a once in a really literally a lifetime opportunity for me to share my story where it may be impactful to what students do in the future or how they, interact with patients or what they go into. So that was my hope. So I looked back in my email, and I think mid-June, I emailed out some students who had worked with me, and they were all very kind, who had done course assistant work with me, and med students, and they were very kind. And then they recruited another student and another student, and it was great. I said, hey, I want to create this course. They're very supportive. They helped me organize it. And, it's just was another way of me giving back and trying to turn something very negative into something positive.
What's one takeaway you hope students would take away from that course?
I think the longitudinal experience of having cancer, of what that is like. In medicine, especially in medical school, a lot of your interaction with patients is episodic, right? There are efforts, great efforts, but it's just difficult to squeeze into a, large medical curriculum, right? So, there are efforts about continuity clinics and so forth. But even then, even like residents, we have difficulty getting, an incredible amount of continuity. You're doing different things, you're on different rotations. And, you may also see patients for different things over time, but it's not so common to get this longitudinal experience with somebody early on with cancer, and from somebody who's kind of got a foot in both worlds, can reflect on it as a patient and can reflect on it as a physician. I think what was unexpected was how broadly this idea, this class was really appreciated from families, from people with cancer, from people with different types of cancer. I've gotten emails from all around the world who just expressed appreciation for me sharing my story. It's not easy to watch 10 hours of classes. It's just free on YouTube. Thousands of people have watched the 10 lecture version, the full version, which is amazing, right? I got this email, and just, make me choke up about how it's a woman who from the Philippines and the US and said, geez, when I look at you, I see my brother. When I look at your kids, I see my kids. And so that struck me, that people, I mean, just the power of storytelling, people, will find commonality, right? Even though there may be many different things about your stories that are different, but you identify with the things that are the same, or that you feel a connection to. So that was unexpected and quite satisfying.
And I do want to talk about joy, because I think some students were surprised. Like, they were taking a class from a clinical professor who was diagnosed with stage 4 lung cancer. And for the most part, you maintained your joy when you taught. I mean, you're a self-described jolly person. That's exactly how I would describe you. And they're taking this class, and they thought it would be about, all of these existential issues, and you're cracking jokes from the back of the room. So I do want to talk about joy and maintaining joy. You also gave the graduation speech to Stanford Medicine graduates in June of 2025. And I rewatched this last night so that I could get this right. And you said, like Lou Gehrig, I consider myself the luckiest man on the face of the earth. Where do you get that gratitude, and what drives your joy even as you've gone through this?
It's funny, I think we were talking about, I actually did some research about like happiness and well-being, and it turns out maybe 50% of it's genetic, because they did this twin study in Minnesota and
But you get no credit.
looked at twins. Well, I would say 50% of it is some sort of genetic thing that I'm predisposed to be happy, because, it's true, right? Some people are just predisposed to this perspective. But I think, the rest of it is an appreciation for how lucky I've been throughout my whole life, right? I was lucky to be born in a family that, loved kids and loved to have a family, and, brought me up in a great atmosphere. My parents provided for me, and, always had food on the table, had a roof over my head. They paid for my education, which is incredible. Brother and sister who really take great care of me and made me who I am, honestly. And now, of course, a fantastic wife who's been just my anchor through all of this, and two amazing kids. So, it's funny, before I was diagnosed, that Lou Gehrig speech has always resonated with me, because when he says those words, I'm like, I also feel that same way.
Mm-hmm.
I'm not a Yankee fan, I'm a Red Sox fan. But, everything he said, I was like, this is amazing because that's what I feel like too. This is how I feel, day to day, that how lucky am I to be who I am and doing what do. And I could sit around feeling sorry for myself, and that sometimes happens. I'm not going to say that doesn't happen. There are some days where I'm like, I don't feel well, or something happened, or I'm like thinking about the future, and I feel a little sorry for myself. But that feeling goes away for some reason. So I think one, gratitude is incredibly important. Two is, I didn't read When Breath Becomes Air, Paul Kalani's book,
Great book.
until I got diagnosed. It's kind of interesting. I never read it, even though our medical humanities and the arts program awards a Paul Kalani Writing Award every year. I had actually never read the book, and it's a fantastic book. I do remember that line. I think part of this is age, because I am at the point where I've accomplished and done and set out to do a lot of things, and done them, where I can be reflective and say, I don't necessarily think about, well, am I going to practice for another 10 years? And recently I closed my clinical practice, but I'm still doing clinical teaching. So I think maybe that's part of the reason my perspective is different. My perspective is that I do think about every day, what should I be doing, right? Should I be spending an hour, being interviewed on the podcast? And I'm like, well, if it's important and I'll enjoy it, and I always love talking to you. So I was like, yeah, that's great. I should do it, right? But there are other things where I'm like, hey, yeah, it's okay. Things that I would probably say no. So I've tried to winnow out those things that are kind of less important, and may focus on things that are more important. Of course, the less important things got replaced by things that are important, like lung cancer advocacy. So I would say my time may be more busy now than it was before. But, I do make an extra effort to spend time doing things I just enjoy on a day-to-day basis. I don't take on indefinite projects as much. I used to. And my rule in the past was like, well, if it's 50%, more than 50% like unpleasant, I'm not going to do it. That's probably like, that's got to be, no more than 20% unpleasant.
The bar had to be
Yeah,
low.
that bar has probably changed a bit. I try to spend like at least an hour a day. It's been cold recently, but sitting in my backyard and just reading just some book, usually fiction, and just enjoying, the weather and the sound of the bees and the, hummingbirds buzzing around. All of those have become important to me. But I've talked to like 20-year-old cancer patients or 30-year-old cancer patients with the same cancer, stage 4 lung cancer, non-smoker. I think my perspective would be drastically different. I think it's because I'm now in my 50s, and my oldest son is in college now. I think it's a different kind of different perspective that I can have.
In your 20s and 30s, you almost necessarily have to do things that you don't enjoy as much because it's an investment in your future self, right?
Right.
There are parts of med school that I'm sure we can both say, like, it was not every moment of our medical training was
Right.
joyful, but it was an investment because you're hopeful that you have that time afterwards, or then you can design your life just like that, where every day is meaningful and you're doing exactly what you want. Do you look at time differently now? Like when you're sitting outside listening to the hummingbirds and an hour passes, do you feel ever a sadness that an hour went by? I mean, are you looking at time differently because you feel you have less of it?
I don't think about 1 hour pass and I'm sad, or if like I didn't make good use of the time. That's going to happen, right? That's life, and that was how I chose to spend my time. I do have sadness, and this is, I got an email from a emergency room attending from my residency. I hadn't talked to him for years, and he sent me an email after he saw some news coverage of me, and it was very kind. And he talked about how his wife actually was diagnosed same cancer, and he wrote in there that he felt a sadness when he would see an older couple walking down the street, and that clicked with me because I had the same feeling. When I see somebody, old couple, walking hand in hand down the street, I do get sad, and I think I won't necessarily have that, right? I hold out hope that maybe I'm a fluke, and kind of speaking back to what you were saying about kind of best case, worst case. Some people look at me and say, God, you look really good. I can't believe you have stage 4 lung cancer. And I talk about how, well, that's, our great treatment and technology. But I also tell them the traditional statistics are, 10% survival rate at 5 years. But I also tell them, well, we don't know what the 10-year survival rates are now with the 5-year survival rates now with new treatments. We don't know because it's not been 5 years since all of these new treatments have been out. I'm on a second line treatment now, which is an antibody plus a targeted therapy, oral targeted therapy, and that was approved last year. And that gives me hope day to day.
Mm-hmm.
That was an early comment that helped me, talking about like that prognosis question.
Mm-hmm.
The pulmonologist who has stage 3B cancer, lung cancer, also Asian, and he said, you just have to live long enough for that next new treatment to come out.
I mean, another question is, how do you want people to treat you? I mean, I think when someone has a terminal illness, it can be instinctive for people to always look at you with the sad eyes. And I think that kind of counteracts your entire personality and your vibe. And I mean, I personally think it would be wrong-headed to leave you out of professional opportunities, or social events or anything that we're doing within Stanford just because you have this diagnosis. How do you want people to treat you?
Myself, and just from the people who talk to, want to be treated like you were treated before, but with the awareness that maybe you're not going to participate as much in certain things. A colleague who's got advanced cancer, different type of cancer, one of his insights was he wanted to just go back to normal. He wanted to get back to normalcy. I think he used the word normalcy, which I think is a lot of people do feel like, can I just get my life back to normal, at least on a day-to-day basis? Do what I need to do, see the people I want to see. And that's hard, right, with cancer. I think the people who treat you differently are the people who maybe don't have any direct experience in their lives with terminal disease. So, the kid gloves come out. And I think part of that's also just speaking back to the class where the students were expecting this sad and this, the dread and, existential conversations is because, they may not have that connection, that personal connection yet. So in a way, that's where I hope my experience is helpful because it shows that not everybody, I mean, there are a lot of people who are, overwhelmed and sad, and it's very challenging when they get diagnosed. And then there are people like me, right? There's a spread of people. We're all different people, right? We're humans. We all react and manage things in different ways. But my hope is my positivity will come out, and hopefully that will help other people.
I did have one patient I remember who was reading also about happiness and cancer. She was a young adult in her 40s with stage 4 colon cancer. And she had read similar research about better prognoses of stage 4 cancer with being happy. But I think in her case, it almost tipped too far. Like she felt this constant pressure, like being happy was a treatment that was as important as the chemotherapy. And in that case, I had to reassure her in the other direction, like, it's okay to have a bad day. Do what you need to do to get through this, and everybody copes with it differently. I do want to also get back to decision making. Have you thought about what might change where you would consider stopping cancer-directed therapies and going on hospice? Is that something you've thought about?
Oh yeah, definitely have thought about it. I think, there's always this joke among physicians about like, especially during a residency, right? It's always very, you're always very morbid in residency, right? People would joke about like having DNR, DNI tattooed on their chest.
Yeah.
Because we see that it's not easy, right? If if you're ill or you require resuscitation or, extreme measures, it's just such a mess and can be painful and challenging. I think everybody, of course, has got it depends on your values and your upbringing and your beliefs about hospice, but also, in end of life care. To me, it's that balance between suffering from the treatment versus potential benefit. Of course, the potential benefit, it's hard. You can't put numbers on those, right? So they're perceived. It's a subjective
There's so much guesswork.
feeling, right?
Mhm.
It's interesting though, I gave a talk to the radiation oncology meeting and talked about how important research was to me, that's benefited me so much, talked about my case. but also talked about clinical trials just briefly. And, there are actually very few studies about why people with cancer participate in clinical trials. And they're qualitative, predominantly. It was really about them expressing optimism, even though they know, like when you push on them and they know, yeah, the likelihood of you joining this clinical trial, of you getting a benefit, is very low.
We've talked about this. I mean, there are certain clinical trials that are only available in certain parts of the country.
Yeah.
So to get that really slim shot of prolonging lifespan, you might have to uproot your entire life and, let's say, move to Texas, move to
Yeah.
Henderson.
Yeah.
You're spending less time with your kids. So it's a really, and there's so much uncertainty involved in making that decision.
So, I'm getting to that point because I'm on second line treatment. When I started, there was really only first line treatment, and then the second line treatment was sort of like vague. There wasn't like kind of a consensus. Now there's, more of a consensus. You know better than me, there are these National Cancer Center guidelines, NCCN, National Cancer Center Network. Is that what it is? NCCN,
National Comprehensive
Comprehensive Cancer. There are these guidelines that insurance follows. So, they've got kind of first line, second line, but there's no third line or fourth line, right? Because we just don't have data and we don't have, this is relatively new. We're making advances as we go. So because I had progression a few months ago, I was transitioned to this new treatment, which is a bispecific antibody, which targets EGFR. And then this oral, again, a different oral treatment, targeted therapy. Also, I had all these insurance challenges. I was denied once for the IV treatment and denied twice for the oral treatment. Posted on LinkedIn and it went viral. I got hundreds of thousands of.
So this was a second line treatment, FDA approved.
FDA approved.
FDA approved, and your insurance rejected.
Denied it. Denied the IV once and the oral twice. So I was like very upset because I was supposed to get the infusion that Monday, and I posted before I went to get my MRI, and then I slowly got hundreds of thousands of views. I think by the next morning.
I'm living in insurance hell, 3 exclamation points.
Yeah.
I actually remember you texted me and you asked, should I post this on LinkedIn?
Yeah.
And I think you were right and I was wrong because I said, well, you should post it on LinkedIn, but maybe tone it down a bit.
I did tone it down based on your suggestion.
Reliable. And then you said something to me like, well, no, it's true.
Well, it's true, but I took out the one line you recommended.
One sentence.
Yeah, you did. That was good. I'm glad we took that out. That was good. That was very helpful.
I've just heard enough horror stories that I may be a little paranoid. So you decided still to post on LinkedIn.
Yeah.
This is maybe the angriest I've seen you because you were a very joyful person.
I never get angry. You
seemed angry in this post. And then it went viral. I mean, the last I checked, it had almost 8,300 likes, 400 comments, 1,700 reposts. And my understanding, you had celebrities reach out to you offering to pay for the medication. I mean, it really went super viral. And then was it the next morning you get a phone call from Aetna?
Yeah, next morning I got a voicemail. I got a new phone, so it like screens out all the stuff. So I just went straight to voicemail. And then it's like, I'm so-and-so from Aetna's executive response team, calling regarding your post. I talked to them, and even before we submitted anything, before we even submitted my appeal letter, which somebody was helping me with, it was approved like about that morning, like later that morning. So within hours of me talking to them, and of course, I'm like, great, I have this platform. People have heard of me. Obviously, I have credibility because I'm a physician and I'm at Stanford. I can get this response. And then, by the way, the next day, the oral therapy was approved, which had been denied twice.
Did they explain why they denied it in the first place?
Not really. The NCCN guidelines, which they follow, but they follow to the letter. So, and this is where the guidelines don't keep up with the reality. They said, oh, we cover this treatment for first line, which is great, but we cover it for second line in combination with chemotherapy. But they don't realize people like me have gotten the chemotherapy already first line because there was a study showing you should be on chemotherapy plus the oral therapy, and that's standard of care now if you can tolerate it. So they need to update the guidelines. And even though it's funny, they never name who rejected it, right? They give you this generic, it's a licensed person, and they even say it could be like a physical therapist or a pharmacist. It doesn't have to be an MD. There's a long list of kind of licenses, and they don't name them. And, you know, this person is just basically reading the guidelines, and who knows, it may be an AI. I have no idea.
I don't know if you remember, there was this piece by ProPublica 2 years ago that I think it was Cigna that they looked at, and Cigna doctors denied 300 requests for payments, and they spent an average of 1.2 seconds on each case.
Oh,
Often they didn't even open the patient's file, meaning there was an algorithm. This was even
yeah.
before I was, all the rage, but there was an algorithm that flagged mismatches, and then the doctor at the insurance company would just sign these denials in bulk without opening the patient's file. Can you
Right.
imagine if we did that on the clinical side?
It's crazy. And then they're not liable too, right? They're not named. In my opinion, they're practicing medicine because they're deciding what gets approved or not. So therefore, it's a clinical decision based on so-called clinical data, right? So I mean, I think honestly, my opinion is we need to get rid of prior auths altogether. The onus should be on the insurance company to go through extra hoops to deny treatment. The onus shouldn't be us to on patients and physicians to get approval for treatment. I mean, especially my oncologist is literally was the president of one of the leading lung cancer research organizations in the
She writes
world.
NCCN guidelines. I think she's one of the
She
authors.
was, I think, in the past. I don't know if she's now, but yeah, it's just like, you know, crazy that they think they know better than my oncologist, who is the one of the leading experts in the world on treatment. And it's not like this is a unusual treatment. This is a, you know, FDA approved, evidence-based treatment.
Yeah.
It's just unbelievable. So I think we should get rid of prior auths altogether. And then if the insurance company really says this is unreasonable, they should be directed to some external organization, which will then judge, is this appropriate or not? There's already a pathway for that. It's called external review, but typically that's done after it's already been rejected once or twice. And then I found out statistics that I heard from actually can't remember where I read it, but you fact check me on this. But you know, I read that 80% of external reviews get approved.
Yeah.
Um,
And I think this all just shows that knowing how the system works was able to help you in so many
yeah.
ways that we just can't expect, and we shouldn't place the onus on patients to ever have
No, or physicians. I
to
mean,
how many, I've done so many of these calls, peer-to-peer,
yeah,
right, where you have to call the insurance company and make the case because something that I prescribed or an imaging that I ordered was
right.
denied. And I'm on the phone for 30 minutes. I'm listening to like the elevator music, and I finally get in touch with a physician. And I mean, no offense, but maybe yes, offense. It might be some retired radiologist who's not, like,
Yes,
not an oncologist, not a primary care doctor, not doing the medicine that I practice. And they're very by the book, as you said. Like they just
yeah,
pull up the guidelines and they say, well, this is what it says.
yeah,
And then I feel like I'm trying to make a medical case to someone that doesn't have the medical
yeah,
background. Like, why do I have to justify
right.
what I'm ordering based on years of experience and expertise? And now it's even more crazy because it's kind of like AI versus AI.
Oh yeah,
So insurance companies are using AI to just very quickly deny things. And then on the other end, like I'll admit, I've used AI, like our practice uses AI
yeah,
to then write the appeal letters because who wants to spend the last study I read showed that it's 13 hours per week that physician practices spend on fighting with insurance companies, whether through
oh,
written letters or phone calls. Like who has 13 hours a week to spend on this? So
right.
it's AI versus AI. It's just a waste of time
It's
for
an
everyone.
arms race.
Yeah, and then people who aren't like you who don't make a viral LinkedIn post, they are the ones suffering the consequences of not getting a life-saving medication approved, maybe for weeks, maybe longer, maybe ever.
And it made it, I just want to make point out, it made a difference in my clinical case. And it's like 9 hours for 2 days in a row because they've got to give it to you slowly. So it's quite a lot. So because I didn't get it that week, my effusion, which is fluid between my lung and my chest wall, got bigger and bigger. It was rapidly accumulating. That Wednesday, I had kind of maybe a fainting episode because there was so much fluid. I was coughing so much, may have fainted for a split second. Wednesday, I asked Paul Ford, I said, hey, can you refer me to the pulmonologist? Because I think I've got a lot of fluid. Because the last time that happened was when I was diagnosed. My lung was half full on the x-ray of fluid. We were in the resident teaching clinic. And I said, hey, this is my chest X-ray. They looked at me and they said, are you not short of breath? Yeah. And then I said, no, but I've got this horrible cough. And then so they set me up. I was able to get a quick appointment with the pulmonary clinic. So they drained 1.4 liters out of my lung.
Mm.
So to me, that a lot of that fluid accumulation happened until I could get my treatment finally was approved. And look, I'm feeling so much better. I mean, that made a difference in my care, that delay, right? It's incredible.
So your cancer progressed in September, I believe, of this year. After 16 months, you decided to close your clinical practice of 20 years, but you still are doing other things like lung cancer advocacy. You're still teaching residents. I'm so lucky that we get to see you in clinic every Wednesday with the residents. What are you focused on now? What are you prioritizing? And each episode is centered around a hard question. So the hard question of hard medicine is, what makes a good life with stage 4 cancer?
I am writing a book. I have to throw that in there. Sorry for the plug. And it's called Sunshine. We haven't finalized exactly the subtitle, but it's basically, how to live life when you're dying. And the book is kind of based on the course, like, lecture. We'll talk about a lecture topic and then talk about a reflection. And a lot of what I talk about is really about, keeps me positive, what keeps me going. So I have a chapter on happiness and sadness. Originally, it was supposed to be just happiness, but like you said, you always have the sadness. So, what do I think about happiness and sadness? I have chapters on serendipity, looking back at my own life about, how serendipity has really played a role in my career and my life. I have a chapter on connections, like human connections, like how important that is. I have reflections on, of course, gratitude, but also on creativity, on curiosity and kindness. And to me, it's just like that's what drives me, right? Being curious, learning new things. To me, it doesn't ever shut off. And there's different ways of being creative. Writing. I've never written a book. I don't consider myself a writer. So that's, part of my new creative output, I guess.
It's fun.
Uh,
It's
yeah,
a fun process.
it's fun and painful.
I'm one of those
There's,
weirdos that actually really enjoyed the process.
I think once I get started, I think the painful part is getting started.
Yeah.
And then,
But
and then
once
the
you're in it,
editing. Yeah. Once you're in it, it's good. Yeah.
I loved it. Like once the
Yeah.
flow was there, yeah.
Yeah. And then kindness, just I think this experience has really reinforced, despite all the craziness now, reinforced my belief in the innate kindness of human beings.
Mm.
People who are, with the experience with the insurance, right? So many people offered to help. They connected me to people. They connected me to this guy, Waris Bukhari, who basically has a whole company, and he did this for me for free. He wrote an appeal letter for me, put in all this data, and all used all the legal lingo, right, which triggers the right responses. Some from drug companies, which I will not name, who basically told me the tricks of demanding external reviews and things like that. Johnson and Johnson even reached out. So Johnson and Johnson makes my new treatment, and of course, they want everybody to have a good response, but they're motivated also by hey, we have a treatment that helps people, right? I mean, you can argue about pricing and everything, but that's a different matter, right? What should drug companies charge for drugs? But they were really, they're activated to make sure, hey, we have an approved drug. Let's make sure it gets to as many people as possible. How do we do that within the existing system, which is admittedly very flawed? So it's just like the kindness of people, the kindness of strangers, the kindness of friends like yourself. It's really reinforced to me just despite all this partisan stuff that we read in the media, about how people really want to help each other. I think the last part is really about happiness. My reflections on not waiting for happiness. I think we see this a lot in people who take professions which require a lot of training, a lot of time that we're deferring. Like we're like, oh, I'll only be happy once I get my MD, or I'll be happy. I'm going to defer my happiness.
Conditional happiness.
It's conditional happiness. And I don't think you should wait for that. I think you should find happiness every day. and not rated. I think we're in this society where we're constantly rating our experiences, right? We're in this Yelp, 5-star rating society, like, oh, geez, well, is that more fun? I'm optimizing my life, right? And to me, that's just not healthy, right? I was driving the other day, and we have these shuttles at Stanford that are called Marguerite shuttles, and they've turned them I think a year or two ago to all electric ones. And the electric ones are really cute. And I was like, oh, that's cool. That was really cool to see. And then I looked, I think it's made by, some company, I think probably in China. I thought it was neat to have this, cool design, new shuttle bus. And, that brought me a little bit of joy, right? But, and am I going to compare that to the joy my kids bring me? I think I'm not going to compare that. What's the point, right? It still brought me, a little bit of happiness and joy. So it's really, I think, that focus on delaying happiness and also just rating our happiness as unhealthy. I think you should, find happiness and joy in everything you do. That's my belief. So that's
Yeah. I mean,
probably
50% of happiness, like you said earlier, is genetic, but it sounds like the other 50% is a choice
yeah,
that anybody can make.
yeah. And it's a framework and a perspective, right? But yeah, I don't want people to think, well, geez, I'm not happy, or, you're clinically depressed. That's not in your control.
Yeah.
But, I think you try your best to find that happiness, find out what makes you happy.
Yeah.
Both the transient things and the big important things in your life.
So the book is called Sunshine. I cannot think of a better title that embodies everything about you. When is it coming out?
So next fall, Crown is the publisher, which is part of Penguin Random House. And Sunshine also because my mother, who's got advanced dementia, one of the few songs she still responds to was really her favorite song. And my favorite song growing up was You Are My Sunshine. So during my graduation speech, I got 3,000 plus people to sing it along with me for my mother who was there, which, was amazing. That was just, I have to say, professional highlight for me.
There was not a dry eye in the room.
Yeah. No, it was a great experience. And my mother actually did sing along, which was great. Yeah.
Yeah. Well, Bryant, thank you so much for taking the hour to speak to me with your very precious time. I so appreciate this conversation on hard medicine.
Well, I appreciate the invitation. Really honored to be here.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.